Zone 3 podcast. Robert here, Reggie, we're the MRI guys, and we're joined today by Dr. Marcotte,
the
cardiac
welcome.
guy.
Morning, guys.
He's a cardiologist. Hi, Dr. Marcotte. Thanks for joining us.
Pleasure, guys.
If you would.
Pleasure to be here, guys.
Yeah, thank you. Thanks for coming. If you would, just tell us about yourself, your background maybe.
Pleasure. My name is Francois Marcotte. I'm a cardiologist. I was born in Montreal, Canada, and I've been here in Arizona for about 3 years. I'm trained as a cardiologist with a specific interest in congenital heart defects, people born with heart defects. I do general cardiology as well. And I also have an interest in cardiac imaging, cardiovascular imaging, non-invasive and non-radioactive or not using x-rays, basically, namely echocardiography and cardiac MRI. And I've been a cardiologist for about 30 years. I've been doing echo for about the same time and MRI for about 20 years. Wow. Always for the heart. I only do heart and great vessels.
Wow. So you've been a cardiologist longer than I believe David has been alive. That's pretty impressive. Wow.
Very impressive. Well, awesome. Thanks for joining us. Thanks for coming today. We appreciate it.
Pleasure.
I guess we're going to be talking about congenital issues for sure today, since that's your specialty. You mentioned different modalities you have experience with. Do you have obviously we have a bias. We're MRI guys, but do you have a bias too? Do you have a preference? Which modality?
I think in terms of safety, I think both techniques, echo and MRI, are extremely safe. What echo brings to the table is flexibility. So it's a small machine. You can bring it anywhere in the emergency room,
Echo
in the
means
ICU.
sonography, yeah.
That's right. So ultrasonography is capable of answering basic questions. If there's fluid around the heart, the cardiac function, and also quite precisely assess the valvular function. Right. Because it's got such a great temporal resolution, the ability to look at things in real time, it's really quite an advantage to use as a first-line tool. We use other things also, like X-rays and EKGs and blood tests. MRI comes in as a more second-line imaging, usually to answer questions that echo can't. The advantage of MRI, as you know, it's been around for decades and discovered initially in the 40s and popularized by Bloch and Purcell as a modality to analyze tissue. And we make pretty pictures out of it, but never forget that MRI characterizes tissue. Right. We can see the difference between fat, muscle, fluid, tumor, and that's really what MRI brings to the table: the ability to categorize tissue.
Nice. Ultra high definition right there. Right?
Ultra high definition, better spatial resolution than echo. Echo has about a 2 millimeter spatial resolution. MRI between 1 and 2, which is still not as good as CT, which is sub-millimeter spatial resolution. So CT brings in that ability to see really, really small things. But CT, no one's perfect. Nothing's perfect. CT doesn't have the temporal resolution. So in terms of doing cines, it's a little bulkier than certainly MRI and most certainly echo. Echo has a temporal resolution of 30 to 60 frames per second. MRI, let's say 25 to 30 frames per second. And CT, we'll say roughly about 15 frames per second. It still does pretty good cine work, but it doesn't have that temporal resolution.
Yeah.
So both MRI and CT are second-line agents. The advantage CT has over MRI is that it's a faster test to do.
Oh, right.
Patients tolerate it better, I find, also. There's less claustrophobia and there's less...
Because it's faster.
It's faster. So the patient doesn't have to stay in the scanner longer. But again, MR is able to look at function in a 3D fashion. Is able to characterize tissue, to see, and with the use of gadolinium enhancement, the official approved use is angiography, but the unofficial or off-label use uses the enhancement of the heart muscle and of cardiac tissues to judge on the perfusion or lack of perfusion of these tissues and helps in categorizing these.
Right.
The added value is a phenomenon called late gadolinium. Well, there's early gadolinium enhancement, which we've used for decades for tumors, but there's late gadolinium enhancement.
So it's like delayed imaging?
Delayed images, yeah. And those have been around sort of since the mid-1990s, came into prime time really in Y2K around, and have been used widely, off-label for 20 years, basically.
Right.
I think this is about to change. I think there are some studies that have come up that have
solidified the use.
Yeah, solidified the use.
Nice.
Looking at perfusion and ischemia in comparison to nuclear myocardial perfusion imaging with nuclear methods, and found quite advantageous using contrast. And I think this should be revised. I'm not going to tell the FDA what to do, but
Right.
my personal bias, I think, is that we've been using it for so long. I think we've grown a little tired of saying, well, this is an off-label use.
Right. Having to explain
because
that.
it's really come into the what we have, our toolbox, basically, to practice medicine.
Now, congenital-wise, do you use MR for a lot of your congenital cases?
Yes. Congenital heart defects are not as common as regular problems like high blood pressure affects 1 in 4 Americans.
Oh, right.
Just in comparison, congenital heart defects affect 1 to 2% of all people.
Oh.
So about 1 to 2% of all people are born with a heart defect. For them, it's a big deal.
Right.
Some of them are blue when they're born, and if not operated or treated with medications, would surely die at birth.
Right.
So now, with the miracles in intervention and cardiac surgery, pediatric cardiac surgery and pediatric cardiology, these individuals that 50 years ago would die, shortly after birth, are now surviving into adulthood. And I'm an adult cardiologist, and I see them when they reach adult age.
Wow.
So I play in. I'm a teammate of pediatric cardiologists who do all the hard work between 0 and 18 years.
Right.
And then at 18 years in one day, basically we come along and we try to match the excellent work that pediatric cardiologists have done, and getting these individuals with a great head start on life.
Wow. Yeah, this is really touch home.
You're succeeding so far.
Well, we're trying not to drop the football.
Well, I know this really touched home for me because I know I was born with a heart murmur. Yeah, and I was lucky enough that I had one where I could kind of grow out of it, which I believe has happened. I'm not 100% sure. I don't feel any heart problems, but I haven't really gotten checked out for that. Now, when it comes to pathologies that are congenital, like heart murmurs, how many different type of congenital pathologies are there?
There are potentially hundreds of different congenital anomalies. The heart actually is the commonest organ affected by congenital defects. It accounts for about a third of all defects found at birth.
That is interesting. Wow.
A heart murmur has to be differentiated from a heart defect. A heart murmur is simply a sound that blood makes as it travels through the heart. And a heart murmur we can hear with a stethoscope. Or
is this something like usually with high velocity? So
high velocity, turbulent flow.
Okay.
Right.
So it may be, there are murmurs. Some murmurs are entirely normal. They're called innocent murmurs. And there are abnormal murmurs or pathological, and that's where we come in and we auscultate, and we obviously will get ultrasound and MR to sometimes categorize these. So a murmur simply means an abnormal sound that the blood makes as it travels through the heart.
I was going to say, because that was actually answers my question, because I'm curious. I would imagine everybody has a sound
potentially, and we see a lot of murmurs
we all have turbulent flow.
In completely normal people. Right. I'll give you an example. When women become pregnant, we often hear heart murmur because the blood travels faster inside the chest, inside the heart. When you're pregnant, your cardiac output doubles, and it's so. The mere friction of blood within the heart can sometimes cause these heart murmurs. People who have other conditions like anemia or infection can sometimes have what we call a hyperdynamic state, and that sometimes can cause murmurs as well. So we have to differentiate these from abnormal murmurs.
For sure.
Examples of defects. Well, the commonest congenital problem is an aortic valve. That's called bicuspid. So normally the aortic valve is a valve that exits from the heart into the aorta, and it's made of 3 leaflets of about equal dimension. Well, some people are born with partial fusion of 2 of these leaflets, or it's called a bicuspid valve.
Wow.
And that happens in about close to 1% of people.
How detrimental is it?
Well, there's like everything, there's a scale. There's varying degrees.
Yeah.
Some kids are born with very tight, very tight valves, and they have a narrowed valve, and they will require intervention, as infants because they have what we call aortic stenosis, which is blockage of the aortic valve.
Is this something you're able to diagnose in a fetal ultrasound?
You probably can. I mean, the fetal ultrasound affords pretty good resolution, and you start. I mean, I think the fetus becomes imageable, if I can invent a new word. I would say probably around 10 to 12 weeks. It's still really, really small of gestation. It grows in size, and typically most ultrasounds are done somewhere between 12 and 16 weeks. I mean, there's variations in practice. Not everybody does it the same way, but I'm saying a lot of people will do it around that time, which affords sufficient growth of the fetus to be visible. Right. Obviously, you remember that there's amniotic fluid, which serves as a like an ideal ultrasound medium for imaging, so we can use that to better see the fetus. We can do the same views that we get in echocardiography and in MRI for that reason. Nice. We can also do MRI even on pregnant women.
I was going to ask you about that, like the risk versus reward. One thing that we can offer for safety with the patient is protection from the 130 decibel sounds that they're but we're not able to add protection to the patient or to the the fetus.
That's right.
So you have to weigh the risk versus reward.
Yeah, we use it again. It's a second line exam. I've used it for congenital heart defects where I'm not getting the full answers to my question by echo, either because the acoustic windows aren't great, or the problem is complex. For example, imaging the right ventricle in someone with a really abnormal heart. The specific case I have in mind is someone with transposition of the great vessels, where you have inversion of the ventricles, or in other words, the right ventricle goes into the aorta. Yeah, it's complex, but so I've used MRI. Typically, we will not image pregnant women before 12 weeks of gestation, and we will obviously not use gadolinium. Right,
but that was going to be
But you can get a lot of information with a dry, and obviously for the reasons you mentioned, we don't do like these exams are very, very focused. Right. We look at function. We can, for example, look at. These exams can usually be done in very efficient states in between 15 and 30 minutes. So we're trying to really, cut down on the amount of time that the fetus is exposed to.
One thing I'm curious about, I've never considered before, is with the fetus development. My understanding, forgive me if I'm wrong, I probably am, but my understanding is that typically the lungs develop later in gestation. So if a patient if a baby is premature, typically they have respiratory issues. But what I'm getting at, is there a window of weeks, in which the baby's more susceptible to congenital heart development?
The heart in itself forms between, it starts at conception, but all the mechanics of the formation of the heart, if I may say that, what we call the embryogenesis, is between 6 and 12 weeks. That's when the closure of the holes of most of the holes inside the heart occur, where the valves form, where the two circulations are separated, the circulation to the lungs and the circulation to the systemic circulation. Now, the thing with fetal physiology is that obviously, as you said, Robert, you don't breathe. Fetuses don't breathe. They're in amniotic fluid. There's nothing to breathe there. So the lungs, although they develop, are not. There's not much flow going there because the function doesn't isn't ready yet, if I can say it. Yeah. So you get about, let's say, 10% of your blood flow that goes to the lung. So that's why most of the blood flow is directed towards the systemic circulation to nourish the brain and the developing organs and the lungs, obviously, because they have to develop too. Right. The lungs will continue to develop for up to 2 years following birth. So they can, the architecture and the arteries and all. Your question probably refers to when our fetus is ready to start breathing and live.
Well, I guess more my question was, is there a certain point where throughout, your 40-week gestation where you feel like okay, good, we've made it past that point where we know their baby's healthy.
We know
if they don't have it at this point, then we know we're good, right?
Yeah, usually your lungs are, major problems will be present usually at 12 to 14 weeks. You should be able to identify, and that's why we do the fetal echo or MRI at that time. The maturity of the lungs to be used to breathe normal air takes more time. There's something in the lungs that's formed that's called surfactant, which helps basically maintain the alveoli, which are like airbags within the in the lungs, if I may say that. and that compound, which takes a little bit of time to form, is available when a baby reaches beyond 32, 33, 34 weeks. That's when
I know a little bit about this because my son has asthma, and my understanding is that's kind of where patients with asthma have the issues, is in their alveoli, and that's one of the late developing.
Asthma, it's more, from my understanding, and I'm not a respirologist, but it's asthma may be in part that, but I think it's mainly what we call the airways. So we call this reactive airway disease. Mm-hmm. So before the airbags or the alveoli lie obviously the bronchi and the bronchioles, and these are small passages, airways, through which air travels in order to get to the lungs. And I think a lot of the people that have asthma have problems more with the bronchi and the bronchioles. Sometimes this is made worse by viral infections that many kids get. We all have to pay our dues in terms of acquiring immunity. So we get exposed to virus, we build our immune system, and sometimes in the process we have some kids have more issues with reactive airway disease. So and that's typically treated with what we call bronchodilators, which are medications that help these loosen the muscles of these airways, because there's little muscles in them as well.
This is awesome. We got a cardiologist we're sitting with, Reggie.
I got to be careful. I'm skating on thin ice.
Well, we're trying to.
I think it's interesting too, because is it more common if you have congenital, like say a lung issue, will you also have like congenital heart issues? Is it like one of those things?
It's tied together, Reggie. Right. So it's a good point you make. We sometimes find that a lot of these patients will have mixed issues. Obviously, the heart and the lungs are a team. They work together. They're a unit that helps. Well, their major function is oxygenation, the blood, and basically circulation. As this tight unit, this team of the heart and the lungs, if the heart's not good, then often the way it manifests itself is through the lungs. Right. If you have heart failure, one of the manifestations is that you may develop water on your lungs because the flow isn't efficient. So in adults, what we call heart failure, or pulmonary edema rather, is one of the ways that people will manifest with.
And to tie that to MR, is that the reason why we do that large field of view through the lungs?
I think it's a big advantage.
MR?
Yeah, I think it's a big advantage. Obviously, there are limitations because of the susceptibility
and everything.
Between, let's say, proton-poor alveoli and the blood vessels. Right. And so we may not be as efficient as CT to look at the lung, but we can see big things. If someone has a nodule, a tumor, these are some of the things that we can see with MR. Even though the exam is not geared, well, the ones I look at are geared for the heart, not geared for the lungs. These are called incidental findings. And they will happen, it's not rare to see. We find incidental findings that in about a fifth of all the cardiac studies we do. That's why we work in close relationship with radiologists cardiology, and all our studies are reviewed by a radiologist to make sure that we don't miss any of those extra cardiac findings. So we're a team there too. We're just like the heart and the lungs. We work as a team, and we make sure that none of these extra cardiac findings are missed. And these are significant, and roughly, even though we find them in 1 out of 5, it's probably maybe 1 or 2% that are clinically meaningful. So a lot of them are like, it's little
cyst or
cyst and stuff that doesn't really carry any gravity for the patients, that are inconsequential. But it's good to know. You want to.
Well, I know
sometimes it's not good to know.
And you got like a congenital case to show us, right?
Well, I have a case, so maybe we can go on and I think this case exemplifies the flexibility that we have in MR. It also makes it important to work as a team. So I tend to be there in the control room when a study goes on, because even though cases get protocoled, we look at the clinical information. We try to do the best. This was an example of a case where I was working with some of my best technicians, and basically the case had been protocoled to look for hypertrophic cardiomyopathy. This was a 25-year-old man referred from an outside provider. So we had nothing on this patient. We hadn't done an echo. We hadn't done chest X-ray. We had nothing. We were doing this for an outside provider. And basically, this young man had left ventricular hypertrophy, which is an abnormal thickness, increased thickness of the heart muscle in the left ventricle. This is the ventricle that pumps the blood, the red blood, towards the aorta and the systemic circulation. So he had this both on EKG, which made the provider get an echo, and they confirmed that. And sure enough, when we looked, these are cine images in steady state of free precession. On the left panel, you have a short axis view at the papillary muscle level that shows both the left ventricle posteriorly and the right ventricle anteriorly. And you see that the function is actually very good, but the thickness of the muscle is quite increased on the left side. Did you want me to point that out?
Yeah, we're just going to give you the cursor if you want.
Okay. So let me see if I can put the arrow here. Okay, big arrow. So this is the left ventricle with papillary muscles here, the interventricular septum. This is the right ventricle. These are the inferior walls, or the diaphragmatic walls. You can see a little bit of liver here. This is the lateral wall. This is the anterior wall. Same thing for the RV, anterior wall, lateral wall. On the right-hand panel, this is a 90-degree view to this view, called the three-chamber view, or long axis. And there we see, so the view on the left is a cut right through here at the papillary muscle level. So this view opens up the left ventricular cavity. It still shows the right ventricle, but only the front part of it. And now we see the aortic valve. Cinema, in steady state of preprecession, because of its properties, is good to show blood flow within the heart. It doesn't show it perhaps as vividly as the classic gradient echo, simply because of the way the sequence is engineered. We don't see blood motion as well, but we can suspect that there is probably something wrong with the aortic valve. There's a little bit of leakage. You can see spin dephasing here in diastole in the aortic valve. The aortic root looks a little bit generous, perhaps. Normally, the aortic root and the left atrium, which is right here, are about of equal size. So you see that the aortic root is bigger than the left atrium, and that there is left ventricular hypertrophy with a preserved function. So, yeah, indeed, this person could have a host of diseases that find, that with left ventricular hypertrophy. Now, the thing with left ventricular hypertrophy, we run into, if we simply look at thickness, we run into the same problem as echo. And there's a host of different things that can give left ventricular hypertrophy. Hypertrophic cardiomyopathy, or HCM, is a genetic condition that affects about 1 in 500 people, where you get transmitted from your parents, one of your parents, and it causes an abnormal thickening of the heart muscle. And the heart muscle is not as efficient in contracting. There's a little bit of what we call fiber disarray. So the myocardial fibrils, instead of being parallel, are kind of a little haphazardly oriented. So the heart doesn't have as much strength, and perhaps this causes a compensatory increase in the thickness. We're not sure exactly how all of that happens, but we know that these hearts are quite thick, and the thicker you are, the more problems you run into, basically, because you've got to feed all that muscle, obviously, and if your circulation, if your coronary circulation isn't good, because often these hearts don't relax properly, well, they don't get the greatest blood flow, sometimes. So it can lead to problems. You can get other conditions, another condition called amyloid, which can also be transmitted genetically, causes an increased muscle thickness, but it's because there's an accumulation of abnormal proteins within the heart muscle. And this also impairs the contractility, because the myocardium has to compete for space with all this protein that's just sitting there, that's amorphous. Right. People who have uncontrolled high blood pressure with end-stage renal disease, obviously will have thick heart muscle. So the commonest cause of left ventricular hypertrophy is actually hypertension. So you can get that with severe hypertension. And then there's another cause here. This is another genetic abnormality called Anderson-Fabry, which is another type of genetic storage disease that can give thickened heart muscle.
So it sounds like it could be treated pharmautically, or a lot of these?
Sometimes, yes. Some of these can be they obviously undoing what nature has dealt you with at birth, and these are in a way they're kind of congenital, but we call them genetic abnormalities. But these abnormalities obviously put these patients at risk of cardiac events. Heart failure, arrhythmia, sudden death. Right. So they have to be looked at, and they have to be evaluated and what we call risk stratified. And MRI plays a pretty big role in doing that. The advantage MRI has over echo is that not only can you look at wall thickness, but for the reasons I've said earlier, we can also give gadolinium enhancement. This is an example of a different patient with hypertrophic cardiomyopathy, and you can see here that. This patient has what we call systolic anterior motion of the mitral valve. The function is just as good. It resembles a lot what our patients has. Mm-hmm. And but when we give gadolinium to these patients, because there's sometimes scars within the myocardium, for the reasons I've exposed, discrepancy between the blood flow that you offer the myocardium and its needs, this sometimes leads to scars. And these types of scars are seen with the off-label use of gadolinium.
That's the late GAD enhancement.
That's right. And you have here an example of this enhancement in the septum that doesn't really correspond to a coronary territory. It's kind of in the middle and typically occurs in the thickest parts and where the hypertrophy is the most severe. But it's kind of haphazardly there within the myocardium. You can see it wherever the myocardium is thickest. I'll move on to the next slide to show you other examples of this is an example of amyloid. Again, if you compare it to our patient, if you look at without gadolinium, different patient. But, you can see that the heart muscle is thickened. The function's a little bit reduced, perhaps. You see that the atria are quite enlarged. And you were asking earlier about the lungs, the field of view. This is an example of a right pleural effusion that's seen readily with steady state of free precession. See how fluid appears quite vividly. You can also see a small posterior pericardial effusion here.
And I've worked with you before, and I know when I see pleural effusion, that's usually when you ask to do that free breathing cine.
Sometimes we do that because within the differential diagnosis of pleural effusion, you have to take in, the commonest cause is heart failure. Right. Related to, a right pleural effusion in particular is going to be heart failure related to, either a low pump function, someone who's had a heart attack or has a cardiomyopathy, mm-hmm. or an excessively thick and non-relaxing stiff ventricle. So these are, when I see, for example, more of a left pleural effusion, that tends to correlate more with pericardial disease.
That's interesting. I didn't know that.
And then, so when I see a left pleural effusion, obviously the commonest cause there would be a left lung problem, like a tumor or something like that. Right. But you can see that sometimes with pericardial diseases. And there, I'll look for constriction, or I'll look for ventricular interdependence with the use of steady state free precession, free breathing. Now, what happens when we give these patients with amyloid gadolinium, because the extracellular space is expanded and there's lots of room between the different structures, look how gadolinium basically floods the myocardium and totally enhances diffusely. This is a really extreme form of cardiac amyloid.
That can't be good, right?
That can't be good. No, and these patients really have not so good a prognosis. So these are the things we sort of think about. We can go to the next slide, David. So these are some of the things we were thinking of for this young man. So we administered gadolinium, and we saw that really there wasn't all that much to write home about. So few, he didn't seem to have.
Still on that. There we go.
There we go. So in the LGE sequences, we don't see much in the way of hyperenhancement. Maybe a little something at the septum. So we haven't quite ruled out HCM, hypertrophic cardiomyopathy, but there's this heart. Another thing that I look at, obviously, the hypertrophy is fairly symmetrical. In genetic hypertrophic cardiomyopathy, it tends to be a little more asymmetric. Not always, but sometimes.
Right.
And the other thing is we can look at the septal curvature. You can see here that it's concave, means it's going inside. It's going outward. In genetic hypertrophic cardiomyopathy, it tends to be the opposite. It seems to be sort of convex and bulge inwards. So these are some of the things, not an absolute criteria, but these are all things that we look at. The thing that struck me, and the reason I went on with so this patient was scheduled to have a perfusion study of his myocardium because we were looking for hypertrophic cardiomyopathy. But I changed the mode of administration of gadolinium in this patient for this particular reason, because as I came in sort of a little late, with my coffee, the text had already started and they were, getting ready to do the thing. I said, well, let me just look at the basic pictures.
Right.
And I put my coffee down and then just start going through. We could see that in the proximal descending aorta, the aorta looked absolutely tiny, which made me think of a potential congenital anomaly. So instead of doing just a perfusion study, I said, time out. We're going to do an angiogram. So we'll or as we say, sometimes a twist.
Right.
So that's what we did in this patient. And really, this showed us that this patient had severe hypertrophy on the basis of hypertension. That was not mentioned by the clinician. Right. And he had a really, really tight narrowing of the proximal descending aorta here. And you have a volume rendered spinning. I don't want to make you dizzy here, but
hold on tight.
But for you MR techs out there, this image he's referring to, the twist, we call that the candy cane.
Yes.
So this is a case of coarctation of the aorta, one of those congenital anomalies that can occur in people.
Is that like a plaque buildup, or?
It's a congenital narrowing of the proximal descending aorta. You're born that way, basically.
Really?
And that particular problem accounts for about, let's say, 7% of all congenital defects. I told you that over half is the bicuspid valve that has two leaf.
Oh, yeah.
It seems like the flow would be very turbulent right there.
Very turbulent, and you can see that there's compensatory collaterals. So the body will not sit there idle. I mean, if there's a severe blockage here, which you can also see here posteriorly, I'm trying to move the arrow not too fast. Right here, this is where the narrowing is. You can see that the body has built its own bypasses. So it's a form of natural bypass that the heart is trying to build to help blood travel from above to below. And you can see that sometimes we see that there can be dilatation of the aortic of the ascending aorta. We can certainly see here that the left subclavian looks a little bit prominent. There's the left carotid and then the brachiocephalic trunk. So in this person, instead of going for medication, what we recommended was a percutaneous coarctoplasty and stenting. So we opened up that. So I referred from the MR lab. I called my colleague in the congenital clinic who's doing cath and intervention. I said, I got a guy with severe coarctation, unknown basically. He's not too symptomatic. He did have severe hypertension, so he had a procedure the following week, and we opened up his coarctation, and he felt a lot better. So
just say like something maybe an atherectomy. I did hybrid kind of IR cases, and we did atherectomies in the lower extremities. But is that something you could do up there?
You could do that. I mean, it's a
to
tight
open up
narrowing.
that.
So typically, what was done in this particular
Or
case,
stented, or I don't know,
that's
grafted.
exactly what we
maybe.
did with stenting. So so MR plays a role certainly here in delineating the severity of the coarctation, of the narrowing.
Oh, right.
You can also see if you're going to be deploying a stent in this area. Well, you want to know where those cerebral vessels and where the subclavians are going to be. Typically, they'll use covered stents, but or they'll use a stent certainly to minimize the risk of recoil.
Right. Yeah.
And the thing with this is that it's been there like this. This has been there for 25 years. He's 25 years old. So there is a small risk if you do plain balloon coarctoplasty. There is a small risk that someone may develop a false aneurysm at the site of dilatation. So that stent really is a bit of a safeguard that helps us minimize this risk. Obviously. Now, this is an approach we can use in an adult. Obviously, if you are dealing with a tiny little baby who's going to grow and you put a stent, it's not it's not the same thing. So in infancy, a lot of these cases presently are going to get operated by capable cardiovascular surgeons specialized in congenital heart defects. But this can be a nice way to take care of a problem, especially if the coarctation is tight but relatively distant from the cerebral vessel, so you don't end up jailing the subclavian artery with your stent, basically. So, and
symptoms was like, could he like? How can go 25 years like that?
Well, he did have hypertension. He did not see doctors very often. And that doctor, I hope, took the blood pressure. But this was certainly not mentioned to us. So we took the blood pressure, obviously, as we do for every MRI case. And obviously, this BP was 170 over 90 in both arms. And we had trouble feeling the pulses in his lower extremities because of the blood flow not good. But this is not part of a normal cardiac MRI. We examined him because we saw findings. But this is just an example of why it's important for the doc to be in the room when you're doing this, because we wouldn't have missed it, but we would have lost a nice opportunity to administer gadolinium the right way for this patient. So I think here you've got to be flexible and you've got to be able to make changes on the fly sometimes to address the specific problem. And be ready for surprises, because cardiac MRI has surprises sometimes.
Right.
And I've scanned many patients with Dr. Marcotte, right? Shoulder to shoulder with me watching. So, and that's extremely helpful. And he's always happy to share his information or his knowledge. And so, there's some doctors that all doctors are awesome, but some are more awesome than others. You're awesome. Thank you.
Thank you.
We touched up on CT versus MRI and the imaging and the differences and the pros and the cons. But one thing I did want to kind of mention as far as the pros and cons is maybe just the volume of contrast in general, because with MRI we're giving 15. It depends on the patient's weight, obviously, but we're giving anywhere from maybe 5 up to 20 cc's, but
it's typically a weight adjusted. The correct dose varies somewhere between 0.1 and 0.2 millimoles per kilogram.
For MR.
For MR, yes. I'm not familiar with the CT doses because I don't practice CTs. I leave that to my radiology colleagues. In MR, some centers, especially in Europe, use 0.1, which gives you a pretty good. So for an angiogram, usually 0.1 is going to be enough. For late enhancement studies, you can probably see significant things. There have been studies that have looked at progressive doses, and obviously the reason 0.2 is used is because it offers the best contrast to noise ratio. I personally use 0.15 based on some studies, published studies, that found that at 0.15 you probably have most of the advantages of 0.2. A little bit more enhancement than you do at 0.1. But I still think that you can get most of the diagnosis with 0.1.
Now, if you're using 0.1, do you have to give more of the contrast, would you say? Or
typically for an angiogram, in order not to oversaturate and get the artifacts that go with that, sometimes we'll if we plan on doing a late enhancement study, we'll typically use as we say, half dose or 0.1 for the angiogram, and then sometimes we'll add a little more. But different practitioners have different ways. I think if you're I mean, like it's done in a lot of MRI, especially in Europe. A lot of practitioners will simply use 0.1. I just find sometimes you may be missing out a little bit on some of the enhancement there.
Right.
So I want to maximize that. There's also timing.
I was going to talk about that.
You have to image sooner.
I've had conversations about the timing, and you said that there's been studies that you said don't worry about if it says a 10-minute delay if you get it at 12 minutes. You can kind of touch on that a little bit.
Yeah, I mean, late enhancement lasts. I mean, there are studies that have shown that you can see enhancement for like 30 minutes or even 40 minutes in large. Now, this is in abnormal myocardium. Oh, okay. Normal myocardium will all be washed away. But there are studies that have looked at late enhancement, for example, in myocardial infarction. And in the earlier you image, if you have a really deeply dead myocardium, we call that microvascular obstruction. When the infarct is really totally demolished the myocardial architecture, and there's no flow going into that. It's called a no reflow zone, and those will appear dark in early imaging between 5 and 10 minutes. But if you're a patient, we don't have the time. We don't want to keep patients in the magnet for 40 minutes. Who wants to? But some studies have shown that if you re-image at 30 and 40 minutes, these areas that are totally non-reflow will eventually start enhancing with time. So that's why I'm saying if you're in the middle of finishing your cine and you're saying if you're using 0.1 or half dose, it might be more important to image early. If you're using 0.2, it may not be that critical. Again, I think this can be argued many ways, and physicists probably have a better handle or better grip on the timing of LGE. But I'm less nervous with that. It's usually if you're 10 versus 12 versus 8. Personally, I don't think it makes a big difference. I think the more time you give, well, obviously normal areas will wash out. Right. The blood pool will wash out, and this leaves your enhanced area to be the lonely the lonely stickler there that's left. So I haven't found it. But obviously, for patients' comfort, we don't want these tests to last forever. We want if you've ever had an MRI and you're in this in this coffin, you want to get out. Your cigar case. It's like so. Right.
Well, and for the MR techs, one thing what you would do is calibrate the optimal TI time. Is you would run a TI scout for the late GAD enhancement.
Using the look locker technology, yes. Yeah.
So I'm curious though, unless a patient is presented to you with an already diagnosis of amyloid, because normally you would run the late GAD enhancements at 8 minutes, but with amyloid you would run it at 4. So, what if amyloid was an incidental finding?
Yeah, well, the thing with early enhancement, it's useful to do early enhancement because in some areas it can help you diagnose areas that are poorly perfused. It also tells you areas that have excessive gadolinium accumulation. Mm-hmm. So you can use that as a comparison, an early versus a classic late. And classic late is typically at 10 to 15 minutes following injection. That's when the classic timing for that. We've pushed the envelope because we want to improve throughput and minimize patient discomfort by shortening the exam to the shortest that's scientifically adequate to get the answer, because we don't want to leave people in there for too long. So it does bring some, and that microvascular obstruction or no reflow zone can be diagnosed in this way, where you see enhancement within normal myocardium and lack thereof in areas that are infarcted, with an early late gadolinium enhancement happening as well. Right. And then as you let more time elapse, the normal myocardium gets rid of the gadolinium. That area that's been centrally necrotic can sometimes start taking up a little bit with time, and then you see the classic LGE in the infarcted zone. That's where. Well,
you mentioned it before. You're able to distinguish between the different tissues better with MR. So
I mean,
it translates to diagnosis.
Yeah, and it I think it's a useful test to do in patients who've had MI. It can bring a lot of information to the table in those where MIs are caused by...
Where something a stress test couldn't do?
If someone's had an MI, sometimes we're a little sheepish in doing a stress test. So in someone who hasn't had an MI to diagnose coronary disease, this is a great test. In someone who's had an MI, sometimes we'll just try to assess the extent of damages first. Mm-hmm. And where I find you can get added value from MR is in those areas where, in those cases rather, where your MI is not explained by a corresponding coronary lesion. Mm-hmm. So let's say you've got you think there's an anterior MI, and then you do a coronary angiogram and you find normal coronaries or minimal plaques, then you say, oh my goodness, how did that happen? Why is there an MI, what looks like an MI on echo and with enzymes, and the patients are sure as hell had pain. So you have all the criteria of the universal definition of myocardial infarction, which is having pain that lasts long, having EKG abnormalities, and having functional abnormalities on non-invasive testing. And then you see, what? There's no lesion. So what is wrong? So did this patient have minimal coronary disease, or does he have something else? Does he have, could he have, for example, a stress cardiomyopathy, also called AKA Takotsubo, or could he have had just a virus, a cardiomyopathy, a myocarditis? Right. So sometimes, or he may have had an MI and simply the artery got reperfused. It was a tiny little blockage that bled. Formed a big clot over it that blocked the circulation for amount of time, and then when the patient was given blood thinners like aspirin and heparin, this blockage washed away, and then you have nothing left behind. That can happen too. So with the late gadolinium enhancement, we can sort of see this kind of this fingerprint, right, this LGE fingerprint for various diseases. Nice. I have a slide. I don't know if we have time later. This actually was a paper that was written by one of my colleagues, Chris Cummings, on the various, and I think it's one of my last slides that I gave you, David. The last one there, the bottom one, yeah. So this is from Dr. Cummings when he was a fellow, and this summarizes the fingerprint of late gadolinium enhancement, what we see when we give that. And, if we see something that's subendocardial or transmural, that typically is something that's coronary or vascular. If we see stuff that's in the middle, or what we call mesocardial, as shown in the upper left. So like our hypertrophic cardiomyopathy case we saw.
Is that meant to represent like a short axis?
It is, yes. That's a short axis view. Sorry,
okay.
Yes.
Okay.
Covered. Good point. And if it's so you can see different diseases may have different fingerprints, and that's how we use this kind of distribution to see, to help.
CSI almost. Huh?
That's right. We're playing CSI. Exactly.
Nice.
Well, thanks for bringing your PowerPoint, your visual aids. Thanks for bringing yourself. I appreciate it. There was certain questions I wanted to ask since you're here. It's not every day we're across the table from somebody who's got more intelligence than us combined. It's lopsided for sure. But like I said, there was certain questions that I had. For example, for my shout out to one of my good friends, Jeff. He's got an irregular heartbeat back in high school. They were going to let him play basketball for that reason. So when we hear that somebody has an irregular heartbeat, what does that mean? How detrimental is it? Can he play basketball? He did, for the record, but go ahead. Sorry.
Irregular heartbeat is a layman's term for arrhythmia. And arrhythmia encompasses a number of different things. An arrhythmia is an abnormal regulation of the heartbeat. The heartbeat typically starts from the base of the heart near the right atrium at a place called a sinus node. So that's where the impulse arises, and then proceeds in the atria, hits a mid-heart relay called the AV node, which is a kind of a buffer zone, and then proceeds into the bundles that innervate, if I can say, both ventricles. There's a left bundle for the left ventricle and a right bundle for the right ventricle. And these are cells that have both contractile, like myocardial, and nervous or neuro capabilities. So they can propagate conduction and electricity. So sometimes mistakes occur. There are arrhythmias where the heart is too slow. We call those bradyarrhythmias. Right. For example, if someone has electrical block, that would be a bradyarrhythmia, and we treat that with pacemakers. If your heart goes too fast, then we call those tachyarrhythmia. Tachy is in tachycardia for fast. I guess it's from the Latin or the Greek.
It's tacky.
Is it also called palpitations?
Palpitations is a symptom that where the person feels an abnormality in his heartbeat, is conscious of his heartbeat, either going fast or sometimes even skipping a beat. So skip beats are common, and they can happen in normal and abnormal individuals. What dictates really the management of people with irregular heartbeats or abnormal heartbeats is one important question. Do they have a normal heart or not? Some people can have abnormal heartbeat, but if they have an underlying heart that's fine, that's good. Right. We always ask about family, because you obviously are the child of your parents, and your parents carry genetic conditions. And again, I'm going back to the congenital and all this stuff. So you see, I'm sort of repeating myself
strong, right? No.
So if you have a family history of sudden death, your dad died at 28 or 33 suddenly, then that's a red flag for us. So we want to make sure that you don't have one of those cardiomyopathies like the hypertrophic cardiomyopathy, or there are other types of cardiomyopathy that are arrhythmogenic, and this is a real medical term saying promoting arrhythmia or abnormalities, and sometimes putting people at risk for sudden death. So our job is really to try to see if these people have, and MR is actually quite helpful to diagnose cardiomyopathies or abnormal heart muscle that cause arrhythmia, that are arrhythmogenic. So we can use that to look for hypertrophic, for arrhythmogenic, or other types of cardiomyopathy. And in those individuals, we may actually step in and say, you may be at risk of arrhythmia and of dying suddenly on the basketball court, as you've seen in some headlines. Now, the thing with hypertrophic cardiomyopathy, which is what most of these, because it's relatively common, 1 in 500 people have this, so not a rare thing. Right. The majority of people with hypertrophic cardiomyopathy do not die suddenly. There are, but we have to try to tease out those that are at risk. If you've got really bad hypertrophy, if your heart muscle is like very, very thick, like 30 millimeters, that's really, really thick. If your family history is loaded with people who unfortunately died suddenly at 25 or 30, you got a cousin, you got a brother or the father or mother, that had sudden death, at 30, that's a red flag too. So we look at all the risk factors, and we try to make an educated guess as to the risk of arrhythmia in those. So determining whether there's organic heart disease underneath and whether your family history is bad are two of the things that we will look for, and try to make the best recommendations. Now, obviously, doctors hate putting a damper on people's life and dreams for either a sports career or just being competitive, because it's in the human nature to be competitive and to do fun stuff like that. So we always feel bad when we recommend that, but we feel better by warning people. Now, there are treatments. Obviously, you can give medication. That can work, but not always.
Depending on the issue, right?
The most definitive treatment for conditions that are at high risk for arrhythmia, and I'm thinking people with hypertrophic cardiomyopathy or arrhythmogenic cardiomyopathy, those really bad ones with bad family histories and very thick muscle, everything I've said is what we call an ICD, an implantable cardioverter defibrillator. We don't put that in everyone because it's a big, you basically have this small computer implanted under your skin that analyzes your heartbeat and can deliver a shock to treat if you have like a cardiac arrest. So this is not something that we put lightly, because these batteries have a certain lifespan. They've got to be changed. Every time you change or you implant, there's a small risk of infection. So it's something that we have to weigh really, really carefully and try to make the best guess and make the best assessment to put it in the right person. Okay. Wow. So this is how we sort of approach that. And MR plays a pivotal role in identifying this. The presence of LGE, indicating scar, fibrosis, sets the stage for mistakes to happen in the heart rhythm. Mistakes happen when areas where the electricity travels normally suddenly hit a wall or get delayed in an area that has fibrosis, aka as seen by LGE. And in those areas, especially the ones where it's kind of a gray in between, where you've got a bit of healthy and a bit of dead tissue mixed in, those gray areas are the ones that have been associated with the worst outcomes. The ones that are like totally dead, there's nothing going through. They can be associated as well. We find that when you have LGE, you have more events: sudden death, heart failure, MACE, as we call them, major adverse cardiac events. MACE. But the ones that where we see a lot of arrhythmia that are often the ones where you've got kind of a gray zone with a mixture of healthy and disease, and that really sets the stage for delays in electrical conduction that lead to like hiccups or extra like a we call that re-entry. It means that you've got a late electrical potential that comes back when the heart sort of try to relax and enjoy diastole for a while and gets this thing, so gets this jolt, and sometimes that can be a bad thing and create like a short circuit where you've got this fast short circuit basically.
Well, is that kind of like AFib? Like
AFib is a very common arrhythmia. Yeah. And that's the classic case of irregular heartbeat. Okay. It's one of the most common arrhythmias, probably second to extra beats, like extrasystole. Mm-hmm. And it happens, I don't want to say it's a normal aging thing, but it happens more in older individuals. It's basically a disease of the atria, the storage chamber. But the commonest cause of atrial disease is ventricular disease. So if you have left ventricular hypertrophy, coronary disease, other things, that can cause that. But it typically doesn't happen that often in young people. We see it under special circumstances when there's a lot of stress on the heart. I'll give you some examples. Let's say you go out and you have a lot of alcohol. The alcohol can have a depressive effect on the cardiac muscle and sometimes trigger these events. So we call this the holiday heart syndrome. Basically, when people have too much booze and then go into AFib, that can happen. People who have sleep apnea, also it puts a little bit of stress because you're basically choking while you're sleeping.
I would think that would be a lot of stress.
Right. Yeah. So you're choking while you're sleeping, but you don't know it. You're not breathing, and you're snoring, and you're trying to get some air in there, and your saturation falls. So we see more AFib in those individuals. We see it more in people who have high blood pressure. For the reason I mentioned earlier, is if your heart muscle's thick, like our young man there, as a result of high blood pressure, the heart doesn't relax properly, and the atria basically can't empty well. So they often dilate more, and there's stretching that happens in the muscles of the heart at the atria. Right. There are certain structures that are kind of fixed and stuck in the lung called the pulmonary veins. Mm-hmm. And when there's stretching between the atria and those veins that bring back the blood to the heart, then that creates stress, and it can cause fibrosis there, and it can cause, again, mistakes where electrical impulses start being delayed, and then you get again this kind of arrhythmia from a mixture of fibrosis and healthy tissue, and that creates AFib.
Right, so that's why they treat it with like beta blockers and whatnot.
You can do that, yeah. There's antiarrhythmics, and you can do sometimes ablation therapy. Oh, yeah. So sort of to take out the half dead or the mixture of alive and dead tissue there. It's kind of like a cauterization. The most important thing if you have AFib is your risk of, because the atria are storage chambers, and if they become sort of inefficient, well, the blood stagnates, and it can create clots within the left atrium and the right atrium, I guess, and these can sometimes detach and cause a stroke. So these people have to be on blood thinners. Whatever you choose to do, if you want to try to, I mean, AFib in itself doesn't kill people. It can wear out the heart, but the most serious complication of AFib is actually stroke. That can occur. So all of these individuals should be on blood thinners, not just an aspirin a day, but they have to be on the more potent ones.
Right.
There's the ones you see on TV there with a Pixaban, or the classic one is warfarin, aka rat poison.
Right.
It was actually discovered as but
I wasn't aware.
Yeah, that's pretty interesting.
But warfarin is very safe. It's not poison. No, it's not poison. It was originally prescribed for that.
Nice.
Yes, it's the classic one, but it requires a lot of blood tests and adjustment. The newer, like a Pixaban, Rivaroxaban, these are drugs that do not need as much adjustment. They don't need blood tests, but they're not good for certain things. Like if you have a metal valve inside the heart, you can't use those because they don't work. Only warfarin and aspirin together work for metal valves, basically. So, anyway.
You have any questions? I got a couple more, but I want to give you opportunity.
Pretty good, actually. AFib was a big one for me. Yeah,
very
These
common.
are just general questions,
and it increases with age because as we age, it's a normal part of aging that the heart becomes a little stiffer. So most people will develop. I guess.
Is it more common in African Americans? Because I guess we have tendency to have higher blood pressure too, right?
So it can. Yes, people who have risk factors such as diabetes, high blood pressure. If you're overweight, overweight brings in a whole bunch of different things that include hypertension, diabetes, high cholesterol, also more sleep apnea. So, because your neck is a little more swollen or fat with, you don't necessarily breathe as good. I'm sort of simplifying it here, but I'm just saying. So that's why it's very important. And yes, so we want to pay special attention to African Americans in terms of getting your blood pressure checked, making sure you've got good blood sugar. Don't smoke. Please don't smoke.
Reggie trying to make it about him.
Yeah, you know.
All right, we can make it about me.
And be careful with your alcohol.
Give the fans what they want, right?
Only 2 drinks at the Christmas party.
Well, one question I did have, again, making it about me. Just a general question. I run pretty often, but sometimes even when I go through the stretches where I don't run at all and I'm really not very active at all, I still have a pretty low resting heartbeat. It's in the mid-50s. And I'm always told when people are testing me that, oh, you must be an athlete, you must be pretty active, even when I'm not very active at all. So what is that usually indicative of? Is that concerning? Is that
I wouldn't be concerned.
Just the opposite?
People who are typically very active will get that what we call resting bradycardia, sinus bradycardia, and the training effect lasts a certain time. I mean, if you stop complete exercising, if you stop moving at all, the thing with active people is that there's many ways you can move. I mean, you can walk.
Right.
You can walk as part of your work. Obviously training creates this slow heartbeat as a result of it reflects the training effect. It's related to increased nervous impulses from what we call the vagal nerve. So you get hypervagal response. So a lot of people who are very fit will have what we call resting bradycardia, and it lasts for a certain amount of time, especially if you're really like a competitive athlete.
Well, and I guess for the fans watching, I've got more of the bodybuild body, right? So, but identify more as a runner, more into cardio and stuff. So, how important is cardio health? And how, as far as like,
it's a good question.
Cardiac health.
I think it's probably one of the most important things to consider. If you want a nice retirement, you want a nice life as an older adult. If you exercise daily and you follow the recommendations of the American Heart Association, exercising at least 150 minutes a week, I think you will have a nice retirement. I mean, stuff does happen. I can't say the other term, but bad things do happen, even if you're doing everything right.
Yeah.
Right.
Exercise will not counterbalance bad genes. So if you have high cholesterol, if you have high blood pressure, and you're saying, no, I'm going to exercise. I'm going to be really thin. And he said, I know I've got high blood pressure, but I'm exercising so much. It counterbalances.
Right.
It doesn't. Rule number one.
Supplements, though? Do supplements counteract?
I don't think they're to my knowledge, of proven value.
Right.
I think a balanced diet, and just look at yourself in the mirror. You know,
Right.
If you like what you see, then there's probably not much problem. You're probably active enough.
Can you overdo cardio?
You can, yes.
Sure. Huh?
And we find that in people who overdo it, well, there's more injuries.
You're talking about like joint injuries and MSK stuff? Or are you talking about like heart
MSK
injuries?
stuff, but also heart stuff.
Okay.
We find that people who overdo it from the heart standpoint are at increased risk of those arrhythmias. That atrial fib you were talking about, Reggie, earlier, it happens more in people who exercise like nonstop.
Long-term athletes?
Yes. So we see a lot of retired, former high-level athletes will have this. Not all of them, but I'm just saying, but it does. It's a relative risk. It's a multiplier. So it increases your risk of AFib, being a maniac.
Right. Don't go too hard in the gym.
Maniac increases your risk of arrhythmia probably 5-fold. It does reduce your risk of heart attack slightly, but you can't just bet on that. So you can't, say, yeah, I'm smoking, but I exercise so much, I'm going to be fine.
Right.
Yeah, I got diabetes, but I exercise so much. It's all good, man. It's all good. It's not. Okay?
You're making the deal with the devil there.
Right.
And the other thing is that sometimes when people will get, like everybody gets a cold or gets the flu and stuff like that. Oh no, I still got to go exercise. Probably not a good thing to do. I mean, so that's one thing that sometimes when these viruses come along, you should probably take it easy and not push yourself.
Try to sweat it out, right?
Yeah, no.
That's good enough.
Give your body a rest.
Right.
So
I think a lot of people just are so used to hearing just the opposite.
Right.
Yeah.
So that's good to
you
hear.
you want to give yourself, we do see the odd case of myocarditis where people where the virus will affect their hearts, and there's experimental evidence that suggests that if, certainly there's animal experiment that suggests that if you exercise mammals who have myocarditis, it's not good in the early going. So you probably should take maybe a few weeks to maybe a month or a couple of months off. Exercise is good. I don't want people to say no, can't exercise. We just had but I'm just saying, use your judgment.
Moderation, right?
In moderation. And once you have a stable condition, I think it's a good thing to exercise.
Right.
Provided your doctor tells you, you're stable on your medications, your blood pressure is good, it's probably a good thing. Right. And again, it's always, you got to use your judgment. The best exercise is walking. There's no question. It's cheap.
Not even swimming?
Swimming's good.
You got to have a pool.
Swimming's good. You got to have a pool.
That's true.
Walking is free.
Higher class Reggie
All you need is a good pair of shoes. Good pair of shoes, good pair of socks.
Right.
And probably the thing you want to be cautious about, and that's an emerging risk factor that probably people should be more aware of, is air pollution. Air pollution. If you exercise in areas where you're jogging there, beside the highway, and you've got motors, wall-to-wall motors pumping carbon monoxide at you, and you're hyperventilating, breathing that stuff, it's probably not that great for you.
Counterproductive.
So it's kind of counterproductive. Yeah. I don't want to say it's equivalent to smoking, but it's probably not benign. So I think you need to choose where you're exercising. You want to breathe where there's clean air.
That's a really good point. Yeah. I do see a lot of runners early in the morning when we're in the busiest times, like, when it's high traffic, and I was like,
we know that if you take a map of the U.S. And you look at the incidence of heart disease, it does seem to follow certain patterns, like where there's more obesity and high blood pressure. But air pollution, it's a pretty good fit to where heart disease is.
I've never heard that connection before.
So cool. I think obviously the lawmakers have to start paying attention to that, and I think that we have to be smart as a society to try to see what's
Yeah, to minimize.
That's good for us.
Yeah.
So we oftentimes hear that heart disease is one of the leading causes of death. And I imagine that's kind of all encompassing. It talks about an umbrella that includes some of the stuff that you mentioned earlier, right?
Right.
I mean, is that pretty much what's going on there when we hear that?
Yeah, still no.
Okay.
Yeah.
Well, I mean, I think we pretty much covered the gist of it. Thanks for coming again.
Right.
I guess for my dad's sake, because I hear this all the time, I do have one last question. Is eggs good or bad for you?
I think everything in moderation is fine. I mean,
you hear that, Dad?
If you have very, very high cholesterol, I mean, there are certain things that are higher in cholesterol, but I think that if you suffer from terribly high cholesterol and you need to be on 3 different drugs to lower your cholesterol, I think you might want to be mindful about that.
Right.
Cholesterol is not all bad. Cholesterol is a compound that makes cell membranes. It's useful. If God put it there, then there's some use for it. So we use cholesterol to make cell membranes and to make hormones and things like that. So it does have its use. The thing is, in itself, it's not just that. It's all the rest that you do. So if you don't move, if you have high sugar, diabetes, high blood pressure, you're not taking your pills, you're not doing your prevention. It's not just one thing that does it.
Right.
Okay. Unless you've got like a horrible family history of these people born with genetic abnormalities of their cholesterol who start having heart attacks when they're like 8 years old, or they're really, and those obviously
rare
those
cases.
are, but those are fairly rare. The familial hypercholesterolemia, that's a rare problem. I mean, most people who get coronary disease will have cholesterols that are mildly or only mildly elevated. So it's all the rest that we do. And perhaps some of those risk factors I talked about: smoking, air pollution, diabetes, overweight, hypertension, and stress probably is
get a good night's sleep, right? Cool. Well, thank you, Dr. Marcotte. You've been great. Yeah.
Pleasure.
Yeah, thanks for coming. That is awesome. Appreciate it.
Awesome.
I know you're a busy man, so we appreciate your time. Thank you.
Pleasure,
Thank
guys.
you for watching.
Yeah.
And thank you for those who subscribe. If you haven't yet subscribed, we need subscribers. That's a great way to show support for us. We are a building
good content
podcast here, so help us build.
Keep it going.
Hit like, hit subscribe, keep watching, tell your friends about us. And thank you again. We'll leave it on that. Zone 3 podcast. We are out.
The information and comments provided in the Zone 3 podcast and website are not intended to be technical or medical recommendations or advice for individuals or patients. The information and comments provided under the auspices of Zone 3 podcasts and their guests are of a general nature and should not be considered specific to any individual or patient, whether or not a specific patient is referenced by the physician, technologist, individual, group, or other entity seeking information. Zone 3 podcast may provide links or references to websites. Such links are provided as a convenience to our listeners seeking more information on topics. These websites are not affiliated with Zone 3 podcast, nor do they endorse or manage content discussions unless otherwise stated during recording.